My lecture today will be about management of endodontic emergency for adult teeth. And I want to make this lecture only for adult mature teeth, not for young immature teeth. So I will focus on the management of the emergency only for adult teeth. So let's start. Let me remind you, 85% of all dental emergencies, they are arises as a result of endodontic emergencies. So 85% of your patients in the clinics, they come to your clinic seeking for help when they have an emergency, and all those are suffering from endodontic problem. So what is endodontic emergency? To say this is endodontic emergency, we should have three elements. First, unscheduled visit. So those patients will come without without any arrangement. So it's unscheduled visit. Second, due to pain and or swelling. And third, this is caused by inflammation or infection of pulp or periapical tissues. So we need three elements. First, unscheduled visit. Second, pain or swelling. Third, inflammation or infection of pulp or periapical tissues. About between 20 to 40% of patients who come to seek care for teeth, they are coming for symptomatic irreversible pulpitis, and 60% of our patients, they come suffering from apical periodontitis. So today we will focus on those two causes of emergency: irreversible pulpitis and acute apical periodontitis. But let me remind you with the goal of endodontic emergencies. Our main goal for management is to quickly and effectively manage pain and infection. We want to stop the pain of the patient, and we want to stop the infection, which might progress to make a severe problem. And we want to minimize the formation of periapical lesion or periapical pathology. This is a common question. Do you think dental pain comes suddenly? I asked this question for all my colleagues in my courses, and most of them, they told me endodontic pain does not come suddenly. Always, we have certain signs or symptoms before the sudden onset. And according to literature, patients who manifest severe pain almost always had previously history of pain with the offending tooth. So we don't have sudden endodontic pain. We always have certain signs precedes the occurrence of endodontic emergency. So, as I told you, we have two types of endodontic emergency, which I like to discuss today. The first one, the emergency due to irreversible pulpitis. And when I say irreversible pulpitis, this occurs in vital teeth. The second type of emergency is acute apical periodontitis. And this acute apical periodontitis, it occurs in non-vital teeth. So let's start first with the vital teeth emergency. And let me remind you, we are talking about adult teeth, which means it is mature. Second, the pulp is vital. We don't have periapical lesion. So let's see how to manage vital teeth emergency. So let me remind you how the pulpitis occurs. And when we say pulpitis means inflammation. So pulpitis, it's inflammation of pulp. But What causes the inflammation of pulp? So when we have caries which will penetrate the entire thickness of the dentine like this here, and the caries is caused by bacteria, this caries, it will cause a cavity inside the tooth and it will progress toward the pulp. So this is the decay as you can see here, and this is the vital pulp. And when we look clinically to the tooth, we will find a cavity filled with decay. And bacteria, it will gain access to the pulp when the dentine distance between the border of caries and the pulp is 0.2 millimeter, which means when the distance between the caries here and the roof of the pulp is less than 0.2 millimeter, it means the bacteria and microbes, it will enter through the dentinal tubules and it will reach to the odontoblast and to the pulp. Next, if this decay is untreated, it will advance toward the pulp and it will destroy the tooth structure in the process. So, if this decay is So what will happen now? The pulp surface, it will becomes colonized by bacteria and it becomes severely inflamed. So as we can see here, the microbes will invade inside the pulp, and as a reaction of the pulp, what will happen? Inflammation of the pulp. At this stage, we have what we call irreversible pulpitis. Irreversible pulpitis means it's a clinical diagnosis based on subjective and objective finding. Subjective, it means the symptoms of patient. Objective, it is the signs which are detected by the dentist. So always when we have irreversible pulpitis, we have to check the history of the patient and ask the patient what he is suffering, and we have to make a clinical examination. When we call irreversible pulpitis, it means the vital inflamed pulp is incapable of healing. Now, let's see what we will hear from the patient, or what we call subjective findings. Our patient will tell us the following things. He will tell us he has spontaneous tooth pain, unprovoked pain. So the pain, it comes suddenly without any stimulus. The nature of pain, it is sharp, severe pain. So now we have two things which distinguish the irreversible pulpitis: spontaneous and sharp pain. Another thing, when we have a stimulus, the response of the pulp, it will prolong for more than 30 seconds. So the third symptom is prolonged response to cold stimulus, more than 30 seconds after removal of the stimulus. So like this lady, while she is eating ice cream, what happens? Severe sharp pain, and she removed the ice cream, but the pain continued for more than 30 seconds. The fourth symptom is referred pain. Sometimes the patient could not indicate where is exactly the pain, from the upper tooth or from the lower tooth. Let's see other symptoms or subjective findings. Sometimes the pain may be accentuated or increased by postural changes, such as lying down or bending over. Sometimes the patient, he will tell you, while I am trying to sleep, while I am in the bed, the pain is increasing. Or sometimes while I want to pray, so when I lie down, I feel a lot of pain. Some patients might come to your clinic holding a cold jar of water, and they will tell you, I have severe pain, but when I drink cold water, this pain decreases for 30 or 40 seconds, then it will come again. What is happening here? When we have irreversible pulpitis, when we drink cold water, what will happen? It will cause vasoconstriction. And this vasoconstriction, it gives 30 to 45 seconds of relief at a time, then the pain will come back. Another symptoms of irreversible pulpitis, no pain or discomfort to percussion. If I make percussion test with the handle of mirror, patient will have no pain. So no pain to percussion. Another thing, if we take X-ray, we will notice slight widening of the periodontal ligament space. It might be evident. So when I take the X-ray, we might find widening of lamina dura, but we will not find preapical lesion, which means the tooth is still alive. What about painkillers? The patient will tell you, I took several painkillers like Brufen, Tylenol, but the pain, it continued and it did not stop while I was taking the painkiller. So now we examined the patient, we took the history, and we knew this is a vital tooth with irreversible pulpitis. Now we want to make the treatment, and the emergency treatment, it is called pulpotomy. So what is the meaning of pulpotomy? Otomy means removal part of the pulp. So pulpotomy is removal the coronal portion of vital pulp tissues, preferably at the level of the canal orifices. So what I'm going to do, I will give the patient local anesthesia, then I will remove all the decay, then I will open the pulp chamber, remove the coronal part of the pulp till I reach the orifices of the pulp. This is called pulpotomy. But why we make pulpotomy? Because this procedure is considered as emergency treatment in permanent teeth until root canal treatment can be accomplished. So what I'm going to do, I will just remove the coronal part of the pulp to relieve the pain of the patient. And the primary reason for choosing pulpotomy, why we are making pulpotomy, we make pulpotomy for one reason only. We have no time to make complete cleaning and shaping of the root canal system. So the lack of sufficient time to clean and shape root canal system is the primary cause for pulpotomy. If I have sufficient time, I will remove the whole pulp. But those patients, as we said, they come in unscheduled visit, and we do not have enough time to make root canal treatment for them, and we want to relieve their pain, so we make this emergency treatment. And they found pulpotomy treatment reduce pain symptoms in nearly 90% of the patient days after treatment. So if I make pulpotomy, 90% of those patients will feel better. Why? First, I will give local anesthesia, as I said, access cavity, then I will remove pulp tissues till the level of the canal orifices, like we do here. So now I remove the whole decay. Patient, he felt pain. I gave him intrapulpal anesthesia. Then I will remove the roof of the pulp. Then I will remove the pulp tissue till the orifices, and I will not use any files here. Just remove the coronal part of the pulp. Next, the question is now I stop the bleeding, and what to place between the first and the second visit, because this patient I have no time to continue. So what to place inside the pulp chamber? They found, according to this article, there is no difference between various antibacterial chamber dressing compared to dry cotton pellet with regard to attenuation of pulp. So either if you place eugenol, or you place any relieving agents, or you place dry cotton pellet, the same effect. So we just place sterile cotton pellet, dry cotton pellet against the remaining tissue. Then I will place temporary filling, and I will give the patient another appointment. The most critical step in pulpotomy is to stop bleeding prior to placement of cotton pellet. And the best way to stop bleeding is to take cotton pellet, keep pressing on the pulp till the blood stops. Usually you might need 5 to 10 minutes. Then I will place cotton pellet and temporary filling. But why pulpotomy? It will reduce pain. Pulpotomy has two advantages. First, it will reduce the elevated interstitial tissue pressure that stimulate peripheral terminus of nociceptor. So when the blood is coming, the pressure will be reduced. So this will reduce the stimulation of nociceptors. The second thing, when there is bleeding from the pulp, it will take with it the inflammatory mediators like prostaglandin, bradykinin, and cytokinin. So this will reduce the tissue level of inflammatory mediators. Now, what if this patient comes to my clinic and I have sufficient time? What to do? I prefer to make single visit treatment. And let me tell you, single visit treatment can be accomplished for all vital teeth which has reversible or irreversible pulpitis in one condition, if you have enough time. So like this patient, he comes with the symptoms of irreversible pulpitis. I had enough time to make cleaning, shaping, and obturation at the same visit. And they found patient experience less frequency of short-term post-obturation pain after single visit than those having multiple visits. So if you can make it in a single visit, do it in a single visit. Another question, should I make occlusal reduction? According to Risenberg, he said vital teeth that are not initially sensitive to percussion, if this vital tooth I made percussion and he has no pain, occlusal reduction has not been shown to be beneficial. So in case of irreversible pulpitis, there is no added value to make occlusal reduction. What about antibiotics? Shall I give him antibiotic? Of course, no. Antibiotics have no effect on pain level in patient with irreversible pulpitis. Now, this is very important question. Can we do pulpotomy for permanent teeth as a definitive treatment or as a final treatment? Because now we are making emergency treatment and we want to continue in the second visit to make the final treatment with the root canal treatment. But the question is, can we make pulpotomy as a definitive treatment? Let's see the answer. According to American Association of Endodontics guidelines, they said we can make pulpotomy for permanent teeth in 3 conditions. First, permanent teeth with immature apices. Second, exposed vital pulp in case of primary teeth. And third, emergency procedure in permanent teeth until root canal treatment can be accomplished. So the answer, according to American Association of Endodontics, we could not make pulpotomy for irreversible pulpitis for permanent teeth. According to Dr. Alan Nasser, he said, in United States, the standard of care is not to do pulpotomy for adult teeth. You could not make pulpotomy for adult mature teeth as a definitive treatment. You can make it as just emergency treatment, then you have to continue and make root canal treatment. Because they consider pulpotomy for as a definitive treatment, it's considered as a negligence. But according to European Society of Endodontics, they have another opinion. They said full pulpotomy may be successful in case where there is partial irreversible pulpitis in the coronal pulp. Then they said we need better long-term randomized data which are required before this becomes the treatment of choice. We are not sure till this moment if we can make it as a definitive treatment because we could not distinguish between what is the inflamed and non-inflamed pulp tissues. According to Dr. Simon, he said there is insufficient clinical evidence to consider pulpotomy for a treatment of every permanent teeth. So what I recommend is don't make pulpotomy as definitive treatment in case of irreversible pulpitis. Unfortunately, some of our colleagues in the Middle East, they are using Pulpotec. And if you read the leaflet of Pulpotec, you can read the following. Pulpotec, it's a filling paste for simple, rapid, and long-term treatment by pulpotomy of vital molars. So let's see if this is right or wrong. What are the components of Pulpotec? It is composed of powder, which is polyoxymethylene, iodoform, and excipient, and liquid, which is composed of dexamethasone, formaldehyde, phenol. And this formaldehyde or paraformaldehyde paste as obturating material, it has been shown as unsafe material. According to American Association of Endodontics and American Dental Association, they don't recommend to use Pulpotec in United States of America. So my second advice to you, don't use it for pulpotomy of mature teeth. Now let's see the second part of our lecture. What if irreversible pulpitis was not treated? So without treatment, this irreversible pulpitis, it will progress and it will cause inflammation of the whole pulp. And this severe pulp inflammation, what will happen? It will cause pulp necrosis. And the pulp necrosis, it will have bacterial toxins. Then those toxins and bacteria, they will progress and they will go to foramen, then to periradicular tissue, and they will cause what we call apical periodontitis or periapical lesion. Now, this patient, he will come to us suffering from the following symptoms. Painful response to biting or palpation. So when he is biting on an apple like this, she is feeling severe pain. If you are examining the tissue over the tooth at the apices, she will have severe pain on palpation. If we check the percussion with the handle of the mirror, what will happen? Painful response. So if you tap, she will feel, or the patient will feel severe pain on percussion. If you are taking X-ray, you might notice we have apical periodontitis like this X-ray. What is the treatment of apical periodontitis? First, local anesthesia, then access cavity. Now, the pulpotomy, it does not work here because the pulp is necrotic and there is no blood pressure to be relieved, so we have to make root canal treatment. And when we want to make root canal treatment, it means we need endodontic motor. And here is an endodontic motor which I use in my clinic. This is from 8 teeth. They have two types of endodontic motors. First, it is the eConnect Pro. It is separate from the apex locator. It has memory program, 6 programs of rotation and 1 program for reciprocation. And you can notice here, this is the eConnect Pro. So you can control the torque, the speed, you can control the forward, backward movement. They have another type of the motor, it's called eConnect, where it is a brushless endomotor with built-in apex locator. So it's not separate. And the speed here, it might reach to 1000 RPM. So we have a wide range of speed you can control. The torque between 0.5 to 4 Newton per centimeter. And it has 11 program from M0 to M10. So let's see here some of those programs. So here you can control your speed, you can choose the reciprocation, the degree of forward and backward movement. So it has a wide range of movement. Now we want to prepare the canal, and let me remind you with the principles of preparation quickly. We will start immediately with irrigation. Then I will make coronal flaring in a brushing movement. So I will attach my flaring file with the eConnect handpiece. Then I will enter 4 millimeter inside the canal. Then this is after removing the coronal part or preparing the coronal part. Now the second step, I will irrigate with the sodium hypochlorite. Then I will take the K file number 10. I will pre-curve it like this here. Now we keep watch winding movement till my K file reach to the periodontal ligament. And how I know it will reach to the periodontal ligament? Now I will attach it to the apex locator. And this is the apex locator which I'm using. It's from 8 teeth, apex. you can see here when my apex locator gives me 0, 0 reading, this is my working length, which I will reach to this point and make cleaning, shaping, irrigation, and obturation. So let's see how it will work. So I will attach it. When my apex locator gives me 0, 0 point, this is my final working length. So I will depend on this point to make my complete cleaning and shaping. So what I advise you, always reach to 0, 0 point and make your cleaning, shaping, and obturation to 0, 0 point. Because if we miss 1 or 2 millimeter, what will happen? Incomplete canal shaping, it will contribute to apical periodontitis like this here. What happened here? This dentist, he did not reach to the end of the canal, and because of this, we still have bacteria in the root canal system. If we reach to the 0, 0 point like this and make our cleaning, shaping, and obturation here, what will happen? We will have complete healing. Then I will check the patency of my canal by making my K fine number 10 goes 1 millimeter outside of the foramen in short vertical amplitude. Like this here, I check my foramen is clean, and then I will make my obturation till the end of the canal. And let me remind you, during irrigation and during rinsing the canal, we have to keep the needle moving apically and coronally with constant and slight movement like this here. So I will take my sodium hypochlorite 5.25 in 5 cc syringe with my needle which has gauge 30, and I will place my needle 1 to 2 millimeters short of the working length, and I will keep irrigating every 3 to 5 minutes with 5 cc for 30 minutes starting the first time I use irrigant. So for molar I need about 30 minutes of irrigation. Then at the end of my irrigation, what I'm going to do, I will take my ultrasonic activator to activate my irrigant. 8 teeth, they have Ultra X, which is ultrasonic activator. It has a frequency of 45 kilohertz. We place it 1 to 2 millimeters short of the working length in each canal for 1 minute, like this here. What is happening here? It will activate my sodium hypochlorite, increase the efficiency, and promote the irrigant to reach for the whole root canal system. So when I use my activator here, it will make my irrigant to reach to the lateral canals and clean the whole area like this. Then when I finish my irrigation, I will dry the canal, I will check my master cone, then I will fill my canal. And nowadays we are using what we call warm obturation technique, or the 30-second obturation technique for each canal. How we will do this? We need what we call two devices. The first one, it will fill the apical part. This device is also from 8 teeth. It's called fast pack device. How it works? I will place my getaperca and the sealer inside the canal, and this is the device. I will place it at 250 degrees. When we press here, this step becomes hot. So when I remove my hands from here, you can see the temperature, it will decrease. So let's see here. I will place my master cone with the getaperca sealer. Then I will place the tip of this fast pack and just I will press. When I press for less than 2 seconds, Now the apical part is filled. What I'm going to do, I will press this part here with a plugger. So the apical part is filled within 12 seconds. Now I want to show you a clinical case here. I have this premolar with 3 canals. That means I need to fill the apical part for those 3 canals in less than 1 minute. Let's see how we do this. As you can see, the apical part of those 3 canals are filled, all of them in less than 1 minute using this fast pack device. Now we will fill the coronal 2/3 of the canal using the second device. It's called fast fill. We will place a getaperca inside this device, and this getaperca, it becomes like soft or flowable getaperca. We will insert it inside the canal. This technique, which is called getaperca gun or scare technique, is so simple. For each canal, it takes about 18 seconds. Let's see how it works. So this is the device here. Now the device is ready. What I'm going to do, just I will place the needle inside the canal. Then I will push on the button here to fill the coronal part. So let's see here. Now the whole canal is filled with this technique. So each canal, it will take 30 seconds using those 2 devices from 80. So let's continue obturation the coronal 2/3 of the premolar, which we treated previously. So let's go. Now all those 3 canals are filled. So such complicated case is filled so easy with those devices within 2 minutes. So let me remind you, to treat the apical periodontitis, we need to do the following: chemomechanical preparation of the infected canal. So we have to shape and irrigate well, then followed by obturation of the whole root canal system, then coronal restoration, and that's it. This will provide the successful treatment. So let's see this case here. I have acute apical periodontitis. We have no swelling. We prepare the canal, we shape the canal, then I place the paper points. The canal was dry. Then I made obturation. Then let's see the follow-up after 5 years or 4 years. You can see the complete healing. My advice to you, if you have acute apical periodontitis in case of necrotic tooth, don't or never partially instrument a canal. You have to make complete cleaning and shaping, because when a canal is entered, its contents must be completely removed. So never partially instrument. You have to make complete cleaning and shaping of the whole root canal system. And according to Hargreaves, he said the effective debridement, cleaning and shaping of the infected root canal system, it will provide predictable pain reduction strategies in endodontic emergency. So this patient, he came suffering of acute apical periodontitis, pain to percussion, no swelling. I gave him local anesthesia, accessivity, cleaning, shaping, irrigation, spent good time with irrigation. Then paper point, the canal was dry, so I can make obturation in a single visit. So the question is always asked to me, can we treat apical periodontitis in a single visit? Of course, yes, why not? In case of symptomatic apical periodontitis, several studies have shown no difference in outcome between single and two treatments. So if you have enough time, go for single visit. And remember always, the golden rule is the following: if we can dry the canal, we can fill it. Although we have a big lesion here, but if my paper point is dry, I will go and make the final obturation. Another question. Now, in case of irreversible pulpitis, I did not make occlusal reduction, but what about acute apical periodontitis? Should I make occlusal reduction? Let's see here. Occlusal reduction significantly attenuated pain. It will decrease pain in patient with periradicular symptoms and preoperative pain 48 hours post-instrumentation. So in case of acute apical periodontitis, if we make percussion test and the patient he is sensitive to percussion test, yes, you can make apical, you can make occlusal reduction. What about antibiotics? Antibiotics have no effect on pain level in patient with acute apical periodontitis, so don't give him antibiotics. But this is a common question when I have to prescribe antibiotics. Let's see here. The absence of blood circulation in a necrotic pulp, it will prevent antibiotic from reaching and eliminating microorganisms. So for those who think antibiotic will reach to the canals, it will not, because there is no blood circulation. So what are the reasons to prescribe antibiotics? We have several reasons. First, fever more than 37.8 degree, malaise, lymphadenopathy, trismus, increased swelling, cellulitis, osteomyelitis. All those cases, they justify giving antibiotics. Otherwise, don't give antibiotics. So they always, you can ask the patient if he has systemic manifestation, fever, lymphadenopathy, trismus, we give him. Otherwise, don't give him antibiotics. So antibiotics are of no benefit for reducing post-operative pain or risk of developing flare-up. So if you make root canal treatment and if you are afraid we might have a flare-up, we don't give him antibiotic, we give him anti-inflammatory. And antibiotics should not be used without concomitant cleaning and shaping. So if you give an antibiotic, you should first make root canal treatment, cleaning, shaping, then you give antibiotics, but they are never indicated as a treatment of pain. What about anti-inflammatory? When we will prescribe anti-inflammatory drug, non-steroidal anti-inflammatory? Patients who present with pain and positive percussion test are almost certainly going to need post-operative medication. So if you make the percussion and the patient he is feeling pain to percussion, those patients almost certainly going to need post-operative medication. So what I recommend is to give those patients non-steroidal anti-inflammatory before treatment, because pre-treatment with non-steroidal anti-inflammatory drug will produce significant analgesia in patients with severe tooth pain prior to definitive treatment. So before starting, when your patient is calling you, I have severe pain, I will come tomorrow morning, so tell him start taking non-steroidal anti-inflammatory. And what we give him, we can give him ibuprofen 400 milligram plus paracetamol 500 milligram 3 times a day. This will provide dentists with an additional therapeutic strategy for managing acute post-operative pain. And always instruct patients to take their analgesia by clock, not per need. So it is as a dose. Tell him you have to take Panadol and paracetamol every 8 hours for a couple of days. What if non-steroidal anti-inflammatory did not work? This suggests that the post-treatment pain is almost likely due to non-prostaglandin mediator, so they need steroids, not non-steroidal drug. So what we will give them? We can give them single dose 4 to 6 milligram dexamethasone intramuscular, and they found 1 ml of intramuscular injection of dexamethasone, it will significantly reduce pain incidence and severity at 4 hours post treatment. So what if the patient they could not take injection? We can tell him you can take oral tablets. In my clinic, you can take 2 tablets, 1.5 plus 1.5, and each 2 hours you can take a tablet. So after 2 hours, 1 tablet, 2 hours, 1 tablet, and 2 hours, 1 tablet. So the sum is 7 milligram. So before ending this lecture, I like to remind you with the main headlines. First, irreversible pulpitis and acute apical periodontitis are the major cause of endodontic emergency. Pulpotomy is the treatment of choice for endodontic emergency, and this treatment is just because we don't have enough time. We can give him another appointment when we have enough time. If you have the time, you can make single visit for irreversible pulpitis. In case of acute apical periodontitis, don't depend on the drugs. You have to make complete cleaning and shaping. And if you can dry the canal, you can make